As reconstructive surgeons, we spend our entire careers obsessing over tissue perfusion, skin tension, and executing the perfect closure. But today we're doing a deep dive into the ultimate reconstructive chess game, which is pressure sore management.
Yeah, and it's arguably one of the most deceptive pathologies you'll face on the plastic surface. I mean, we all know a stage 4 defect when we see it on consult rounds. The bone is literally staring right back at you.
Right.
But a really common pitfall is treating that surface presentation as the perimeter of the problem. What you see on the skin is it's really just a tiny fraction of the total tissue destruction happening deep within the pelvic girdle.
And the stakes for mastering this are incredibly high for your daily practice. We're dealing with an issue that affects, what, roughly 9% of all hospitalized
Yeah,
patients?
which translates to about 2.5 million people every year.
Wow. And contributing to over 60,000 deaths. So this isn't just advanced wound care. It requires a profound mechanistic understanding of the pathophysiology. Plus, you need a surgical strategy that anticipates the patient's needs, 5, 10, or even 20 years down the line.
Exactly. Which means we really need to discard the idea that these are simply surface ulcers that need a little debridement and a flap. To definitively reconstruct these defects, you have to understand the capillary mechanics driving the necrosis.
Let's unpack those mechanics, actually, because the visual we get on the floor is a surface wound, but the trigger happens at a microscopic level deep at the bone-tissue interface.
Right, and the foundational concept here goes all the way back to those classic Landis studies on capillary dynamics. Normal capillary pressure on the arterial end is about 32 millimeters of mercury.
Which is practically nothing.
Yeah, it's nothing. It's a mere whisper of pressure, keeping those vessels open. So the moment the external compressive force, whether that's from a standard hospital mattress or a specialized wheelchair cushion, the moment it exceeds that 32 millimeters of mercury, the capillary bed physically collapses
The perfusion just stops.
entirely, and localized ischemia begins.
But just the weight of a patient's own pelvis resting on a bed far exceeds that 32 millimeter threshold.
Oh, absolutely. But here's the key point. What makes this mechanism so destructive isn't just the absolute pressure. It's the relationship between the applied pressure and the duration of time.
Right.
Daniel and Dinsdale mapped this out beautifully in their animal models. They showed this strict inverse parabolic relationship. So a massive acute spike in pressure can cause deep tissue necrosis very quickly.
Makes sense.
But alternatively, a relatively low amount of pressure, say just slightly above that 32 millimeter threshold, that can cause the exact same catastrophic damage if it's applied steadily over a long enough period.
Which brings us to the biomechanical paradox that makes these consults so frustrating. Muscle tissue and skin tissue, they do not tolerate ischemia equally.
Not even close. Muscle is highly metabolically active. It demands continuous oxygen delivery just to maintain basic cellular function. Skin, on the other hand, is remarkably resilient.
Right. In those classic models, applying 500 millimeters of mercury for 2 hours caused total irreversible muscle necrosis deep at the bony prominence.
Yeah, but the skin overlying that dead muscle, it didn't actually ulcerate until they pushed the pressure to 600 millimeters of mercury for a full 11 hours.
So by the time the floor nurse pages you about a new stage 2 breakdown with, some partial thickness dermis loss, the gluteus muscle sitting next to the ischium has already been dead for an entire shift.
Exactly.
I always think of it as a reverse volcano. The eruption doesn't start at the surface. It starts deep at the epicenter of the pressure, right against the bone.
That's a perfect analogy.
And that cone of ischemic injury just spreads outward and upward toward the surface, making the skin the absolute last structure to succumb.
And that reverse volcano concept dictates your entire surgical approach, because if you only excise the visible crater on the skin, you're leaving behind a massive subterranean cavern of necrotic muscle and compromised fascia.
Right.
And ischemia is only the initial trigger. Once that deep tissue dies, it sets off this inflammatory cascade that fundamentally breaks the normal wound healing sequence.
Normal acute wounds transition smoothly, right? Through inflammation, cellular migration, matrix formation, but chronic pressure sores just stall out completely.
They become molecularly hostile environments. The matrix metal proteases, the MMPs, they become completely unchecked.
Right, because in a healthy wound bed, MMPs act like a demolition crew, clearing out the dead tissue so rebuilding can begin.
Yes, and tissue inhibitors of metalloproteases, or TIMPs, act as the site managers, keeping that crew from destroying healthy structures. But in a pressure sore, that regulatory balance is totally destroyed.
The MMP levels skyrocket.
Exactly. The TIMPs are suppressed, and the wound bed essentially digests its own granulation tissue as fast as the body can produce it.
And when you add spinal cord injury to the mix, which is, the baseline for a huge percentage of this patient population, you encounter another massive physiological hurdle. Denervation actually changes the vascular behavior of the tissue.
It introduces profound edema. When a patient suffers a spinal cord injury, the denervated tissues below the level of the lesion lose their sympathetic tone.
Meaning the blood vessels massively vasodilate.
Right. They become continuously engorged, leading to severe plasma extravasation. I mean, consider that normal soft tissue is already about 80% fluid.
Yeah.
When you combine the loss of sympathetic tone with external pressure trauma, plus a flood of inflammatory mediators like prostaglandin E2, the cell membranes simply leak fluid into the interstitial space.
So you end up trying to heal a wound in a completely waterlogged, hypoxic environment. Well, I have to play devil's advocate here for a second. Let's talk about the clinical reality of preoperative optimization. Because the standard textbook teaching is that you cannot take an unoptimized patient to the OR. You need an albumin over 2.0 grams per deciliter.
Sure.
But in real life, I've seen patients with massive, weeping stage 4 sacral wounds who are dumping protein out of that wound bed every single day.
Oh, all the time.
You can run continuous enteral tube feeds, give them 3 grams of protein per kilogram, and their albumin will not budge a millimeter until you actually surgically close the hole. So aren't we caught in a clinical catch-22?
It's honestly one of the most difficult judgment calls in reconstructive surgery. You're absolutely right that a massive open wound is a metabolic sink, but you have to separate the concept of achieving perfect lab values from the concept of reversing a catabolic state.
Okay, explain that.
The hard stop isn't necessarily a perfect albumin level. The hard stop is taking a patient to the OR who is actively malnourished and in a state of severe negative nitrogen balance.
Got it.
Because if you flap a patient whose physiologic environment cannot physically build new collagen, that flap will dehisce on day 7, guaranteed. So you have to push the nutrition as aggressively as medically possible, often needing the dietitians to provide massive caloric and protein loads while simultaneously optimizing every other variable you can control.
And one of those controllable variables is the bacterial load, which is another area where standard floor management often misleads the surgical plan.
Oh, completely.
A wound gets swabbed, the culture comes back growing 5 different organisms, and the primary team wants to delay surgery for 6 weeks of IV antibiotics.
Yeah, and surface swab cultures of chronic pressure sores are clinically useless.
Totally useless.
They provide zero actionable data for flap reconstruction.
Yeah.
All a swab tells you is what type of biofilm is colonizing the superficial exudate. Every single chronic open wound is colonized.
Right. If you want to know if the wound bed is actually infected, meaning bacteria have actually invaded the viable tissue, the only gold standard is a quantitative tissue culture obtained after a sharp surgical debridement. So what specific numbers change your surgical management?
The universally accepted threshold is 10 to the 5th organisms per gram of tissue. Anything above that number is diagnostic for an invasive soft tissue infection.
And if you ignore that,
If you attempt to rotate a musculocutaneous flap over a wound bed carrying a bacterial load higher than 10 to the 5th, the metabolic demand of those bacteria will just outcompete your flap for oxygen. It is highly predictive of total surgical failure.
wow. And it gets significantly more complicated when the infection reaches the bone. Once you're staring at exposed ischium or sacrum, osteomyelitis has to be your baseline assumption.
Yeah, just like the soft tissue, you cannot diagnose osteomyelitis with a superficial swab. You need an actual bone biopsy to identify the offending organism, and ideally, an MRI to map the anatomical extent of the marrow involvement.
Right.
But the crucial takeaway for the surgical team is that chronic osteomyelitis in a pressure sore requires a surgical solution. Medical management alone will fail.
Because you can't rely on systemic antibiotics to penetrate heavily sclerotic, avascular, necrotic bone.
Exactly. You have to physically resect the diseased bone back to bleeding healthy margins.
Which brings up a fascinating biomechanical challenge, the ostectomy. Managing the bone is this super delicate balancing act. You have to remove the infected tissue and the prominent bony edge that caused the initial pressure point. But if you get overly aggressive...
You create a completely new set of problems.
Right.
The radical ostectomy is a classic trap, particularly with ischial ulcers. The surgical instinct is often to perform a total ischectomy. The logic being, if the bone is gone, it can never cause another sore.
Sounds great in theory.
But the pelvic girdle is a closed biomechanical system. When a seated patient loses an ischium, their body weight doesn't just disappear.
It just transfers.
Right. A total ischiectomy will predictably shift the seating pressure to the opposite side, virtually guaranteeing a contralateral ischial ulcer within a few months.
So you're basically playing a high-stakes game of biomechanical whack-a-mole.
That's exactly what it is.
Because if you chase that new ulcer and perform a bilateral ischiectomy, the pressure then shifts centrally. Now the patient is resting all their body weight directly on their perineum, leading to perineal ulcerations, urethral fistulas, just devastating urologic complications.
Which is why the surgical rule is absolute conservatism. You take only the absolute minimum amount of bone necessary to clear the infection and smooth the prominence. You want to flatten the peak of the mountain, not level the entire mountain range.
That makes total sense. And while you're evaluating the bone and the wound bed, you also have to evaluate the patient's baseline biomechanics, specifically spasticity and contractures, which is paramount in patients with high cervical and thoracic spinal cord injuries.
Oh, it's massive. Spasticity generates immense shear forces. A well-perfused, beautifully designed flap can be literally torn off its recipient bed if the patient goes into a severe flexor spasm postoperatively.
Yeah, you have to aggressively manage this before you ever bring them to the OR.
Absolutely. That means maximizing medical therapies, baclofen, diazepam, dantrolene. Targeted Botox injections into specific spastic muscle groups can be highly effective too.
And if medical management fails,
Then you have to escalate to neurosurgical interventions, whether that's an intrathecal baclofen pump or even a rhizotomy to permanently interrupt those spinal reflex arcs.
and contractures present a similar physical barrier. Severe hip flexor contractures will physically drive the greater trochanter right through the lateral skin, no matter how thick your flap is.
Right.
Sometimes physical therapy isn't enough, and you have to perform surgical tenotomies to release the joint. But that introduces a brutal trade-off.
It really does.
If you do aggressive tenotomies on a patient who relies on their legs for stability during wheelchair transfers, you might leave them with a completely flail extremity. You cure the ulcer, but you permanently destroy their independent mobility.
Which is why it requires a multidisciplinary discussion with the patient, physical therapy, and the surgical team to map out what their postoperative life actually looks like. And before finalizing the operative date, do not ignore the metabolic markers. Hemoglobin A1C is a ruthless predictor of outcome. Data consistently demonstrates that an A1C greater than 6% is directly associated with massive increases in both immediate flap dehiscence and late recurrence.
Okay, so let's say the patient is fully medically optimized. The spasticity is controlled, the A1C is acceptable, the quantitative tissue cultures are below 10 to the fifth, and the bone has been properly managed. You're finally ready to close the defect. The first principle here is recognizing why primary closure is a guaranteed failure.
Yeah, never attempt to primarily close a deep pressure sore. It's an incredibly tempting maneuver, especially when you sharply debride the edges, mobilize the surrounding skin, and realize, hey, I can easily reapproximate these margins.
Just throw some deep dermal sutures in there.
Right, but you have to remember the mechanics of the reverse volcano. A pressure sore is not just a laceration. It is an absolute three-dimensional tissue deficiency.
You're essentially trying to stretch a thin layer of skin over a giant anatomical void.
Precisely. And if you pull skin together over a deep void, directly resting on a bony prominence, that closure is under extreme intrinsic tension. There is zero soft tissue padding to absorb the mechanical forces of daily living.
So the moment the patient puts weight on it,
The incision will dehisce immediately. For the same reason, simply throwing a split-thickness skin graft into the defect is doomed. A skin graft provides absolutely no structural bulk or durability against future pressure.
you need vascularized, bulky flaps. And this is where the reconstructive chest game really begins. Treating pressure sores requires you to plan your next 3 surgical moves. Because recurrence rates are historically so high, if you burn a specific flap today, you severely limit your options when the patient inevitably returns in 5 years with a new breakdown.
Right.
Let's break down the strategy by anatomical location, starting with ischial defects in seated patients.
So, ischial wounds are notoriously difficult because the patient must eventually return to a seated position to maintain any quality of life. The constant mechanical load drives recurrence rates incredibly high, historically cited up to 75%, though modern techniques have improved those numbers a bit.
Right.
The workhorse options here are the inferior gluteal musculocutaneous flap or the VY hamstring advancement flaps.
The inferior gluteal flap is a perfect example of keeping your options open, actually.
It's a brilliant design. It's based on the inferior gluteal artery and utilizes only the lower half of the gluteus maximus muscle.
Right.
By designing it as a rotation flap from the inferior portion, you provide excellent bulk over the ischium without violating the posterior thigh tissues. So if the ulcer recurs a decade later, you haven't burned the bridge. You can still harvest a posterior thigh flap or utilize the hamstring muscles for a salvage procedure.
That's incredibly smart. And speaking of the hamstrings, the biceps femoris or semimembranosus flaps are usually designed as a VY advancement. They're highly reliable, but the biomechanics of the closure can be tricky.
Very tricky.
Because when you advance that tissue, the final suture line often ends up resting directly over the point of maximal pressure. When the patient flexes their hip to sit, it places immense tension directly across your repair.
Exactly. Now, moving to the supine patient, sacral defects require a totally different approach. Here, the gluteal flaps are the undisputed gold standard. The gluteus maximus is a massive, highly vascularized muscle that can be manipulated in multiple ways.
Yeah.
You can base the flap superiorly or inferiorly, use the entire muscle or just a portion, and design it as a rotation, advancement, or even a turnover flap. It delivers phenomenal bulk and a robust blood supply straight into the heart of a large sacral void.
Beautiful. Finally, we have trochanteric defects, which typically arise when patients are positioned laterally. The tensor fascia lata, or TFL flap, is the go-to solution here. It provides a long, durable paddle of tissue based on the perforating vessels from the TFL muscle.
It's reliable, but the TFL comes with a major physiological caveat. The distal tip of that flap, the portion farthest from the vascular pedicle, relies entirely on a random, non-axial blood supply.
Right.
So if you have a massive trochanteric defect that requires a very long flap to achieve coverage, that distal tip is at extreme risk for ischemic necrosis.
Which means you might have to execute a surgical delay procedure.
Exactly. A delay procedure essentially means making your surgical incisions and undermining the flap, but leaving it attached to its native bed rather than transferring it immediately.
Right, to train the blood supply.
Yes. This controlled ischemic stress forces the vascular choke vessels to open up and dilate, supercharging the blood supply to that distal tip over a couple of weeks. Once the tissue is trained, you return to the OR for the final rotation.
And when you finally do rotate the TFL, you are often left with a T-shaped junction at the donor site closure. That junction is notorious for tip necrosis and dehiscence due to massive tension.
Oh, yeah.
In many cases, fighting to close that donor site primarily just creates a second wound. It is often safer and smarter to simply lay a skin graft over the donor site muscle, completely eliminating the tension on your primary reconstruction.
The surgical execution is demanding, but getting the flap to survive the OR is truly only step one. The real test of your reconstruction begins the moment the patient leaves the recovery room.
Yeah.
The postoperative management requires absolute rigid discipline from the nursing staff.
And this is a major paradigm clash, right? Modern surgery is all about early recovery after surgery protocols. We want joint replacement patients walking down the hall on the same day. But with pressure sore flaps, we demand absolute immobilization and zero pressure on the surgical site for 2 to 3 full weeks. The patient is just locked down.
Because there is zero margin for error here. You have to remember the state of the microvasculature in a freshly transferred flap. It's completely dependent on its primary pedicle. It hasn't established any collateral flow with the surrounding wound bed yet.
Right. Just like we obsess over millimeters of tissue tension in other reconstructions, we have to obsess over mechanical load here.
Exactly. If a patient sits on a fresh ischial flap on post-op day 4, the mechanical weight will instantly collapse those fragile capillaries. You will induce localized ischemia and completely kill the tissue you just spent 6 hours transferring.
Unbelievable.
They must be managed on a specialized air loss mattress, adhering to strict 2-hour turning schedules that completely offload the operative site.
And when you finally initiate the reseating protocol, it has to be hyper-gradual. You don't just clear them to sit in a wheelchair for dinner.
No, you start with a maximum of 30 minutes in the chair on the very first day. Then, you meticulously inspect the flap for any signs of venous congestion, dusky discoloration, or capillary refill issues.
Wow.
If the flap tolerates it, you add another 30 minutes the next day. It is a painstakingly slow process. And naturally, you must ensure their wheelchair has been comprehensively refitted with appropriate pressure-distributing cushions before they ever initiate a transfer.
But even after the wound is fully healed and they're back to their daily routine, the data shows they're not remotely out of the woods. The vulnerability window for a recurrence is shockingly wide. The highest risk period spans the first 15 to 22 months post-operatively.
Yeah, recurrence rates after a successful flap closure still hover around 39% globally. The driving factors are generally systemic, poor long-term glucose control, chronic hypoalbuminemia, and, ironically, younger age.
Younger age.
Yeah, younger patients tend to be more active, which naturally subjects the reconstructed area to more frequent and severe shear forces. If a patient carries multiple risk factors, the long-term success rate drops precipitously.
Which forces us to address the most devastating long-term complication of chronic pressure wounds, the margin ulcer.
A margin ulcer fundamentally changes the trajectory of a patient's life. It is a highly aggressive squamous cell carcinoma that arises directly within the bed of a chronic, non-healing wound.
Right. We typically associate SCC with slow-moving skin cancers, but the malignant transformation that happens in a chronic inflammatory environment is vicious.
It is. The constant cellular turnover, the chronic DNA damage from the inflammatory mediators, it breeds a particularly malignant cell line. The metastasis rate is alarming, hitting roughly 61%.
61%. To put that in perspective, carcinomas that arise in old burn scars only have about a 34% metastasis rate.
Yeah, and the timeline is also clinically deceptive. Classical teaching suggests it takes 25 years or more for a margin ulcer to develop in a chronic wound bed. But modern literature shows they can present in as little as 2 years.
2 years. It's terrifying.
If you're evaluating a chronic pressure sore and you note heaped up, indurated margins, excessive foul-smelling bleeding, or rapid morphological changes, your clinical suspicion must be extremely high. You have to biopsy multiple distinct areas of the wound bed.
And if the pathology returns positive for SCC, the reconstructive plan goes out the window, and you enter oncologic salvage mode.
Exactly. The protocol mandates wide surgical excision with substantial margins. Prophylactic lymph node dissection isn't typically recommended unless there is clinically palpable nodal disease, but you're almost always consulting radiation or medical oncology to discuss adjuvant therapy based on the depth of invasion and resectability.
Right.
It highlights exactly why letting these wounds languish for years on the floor is so profoundly dangerous.
Absolutely. Well, let's bring all these concepts together for daily practice. When you get that Friday afternoon consult, what are the absolute non-negotiable principles you need to operate by?
Okay, first, respect the deep ischemic penalty. The skin breakdown is just the tip of the iceberg. Anticipate massive underlying muscle necrosis. Second, enforce strict preoperative optimization. You need an aggressive nutritional plan, rigorous spasticity control, and quantitative tissue cultures proving your bacterial load is below 10 to the fifth. Third, practice extreme conservatism during your ostectomies. Do not shift the biomechanical burden. And fourth, treat your flap selection like a long-term chess match. Preserve your future reconstructive options because the statistical reality is that you will likely need them.
It's a surgical subspecialty that demands intense medical discipline. And, it leaves me thinking about the future of this pathology. We pour incredible resources into mechanical offloading, advanced turning beds, high-tech wheelchair cushions, continuous monitoring. But given everything we just discussed about the underlying pathophysiology, the fact that denervated tissue loses its sympathetic tone, becomes massively engorged, and is primed for rapid ischemic death.
Right, it raises the question of whether mechanical solutions are simply fighting a losing battle against a physiological inevitability.
Exactly. What if the next major breakthrough in preventing pressure sores isn't a better mattress? What if it's a targeted pharmacological intervention, a local injection or synthetic topical, designed to artificially restore sympathetic tone and maintain capillary perfusion in those vulnerable denervated tissues before the pressure even hits that critical 32 millimeter threshold?
Shifting from reactive mechanical management to proactive, localized medical prevention would completely redefine how we approach spinal cord injury care. It's a massive area of untapped potential.
Something to think about the next time you're standing at the bedside, looking at a simple patch of non-blanching erythema and knowing exactly what kind of destruction is already brewing underneath.